Dear all, thank you for being so patient while others were joining. Welcome to today's ERN-RITA Webinar. I'm Dr. Jordi Antón, pediatric rheumatologist at Hospital Sant Joan de Déu, professor at the University of Barcelona, Spain, and chair of the Education and Training Committee of the Pediatric Rheumatology European Society. First of all, I would like to thank Tadej Yapsin and the organizer of this great ERN-RITA webinars for inviting me to host this session. I'm especially honored to introduce Dr. Fabrizio De Benedetti, sure well known by most of you. He's a colleague, pediatric rheumatologist, great researcher, and a teacher capable of presenting the most difficult concept as easy and always with a fine sense of humor. Fabrizio De Benedetti received his MD PhD from the University of Pavia, where he trained as a pediatric rheumatologist. Between 1992 and 2002 was medical director at General Pediatrics and Rheumatology at San Mateo Polyclinic in Pavia. And since the end of 2003, he's at the Bambino Gesù Children's Hospital in Rome, when he served since 2010 as head of the Division of Pediatric Rheumatology and the head of the Laboratory of ImmunoRheumatology. Bambino Gesù is an active member of the ERN-RITA. And Dr. De Benedetti's research is focused on the pathogenesis and the role of inflammatory cytokines in pediatric rheumatic diseases. His research has been translated to the development of novel targeted therapies in their clinical trials, and he has led more than 10 phase 2 and phase 3 trials. His research has led to several publications in journals like New England Journal of Medicine, Journal of Experimental Medicine, JC+1, and also rheumatic diseases, etc. Active member of associations like Printo, eSite. He's current member of the Press Council and chair of the research committee. Dr. De Benedetti is a smart researcher, intelligent and incisive with his observations. He's a good friend, I must say. And he accepted to review today's knowledge about HLH, primary and secondary like the macrophage activation syndrome, and remark the key research and studies that are going on, in several of which his team research plays a key role. I'm sure that we all will enjoy his presentation. Fabrizio, grazie mille per aver accettato di farci questo discorso qui oggi. Prego.
That was a surprise, Jordi. I didn't know you could speak so perfect Italian. So don't believe one word that Jordi said. He had a disclaimer and a conflict of interest. We are very good friends, and this is one of the nice things of our job, to meet good friends. Can I share my slide? Thank you very much. So what is the, let me make it right, because this is going to be messed up on my two screens. That's it. So I was asked by Tadej and Jordi to talk to you about hyperinflammation, HLH and MAS, and I think the common word here is too much of a response. And these are my disclosures, apologies, and these are some of the readings you might want to look at. The number of papers published under keywords MAS and HLH has almost doubled in less than 2 years. It's a lot of stuff. I'd like to start from the concept of autoinflammation and hyperinflammation. I think we are all very familiar with the concept of autoinflammation. When the inflammatory response is activated in the absence of, of a real trigger, or the presence of a trivial trigger like cold exposure, and this inflammation leads to damage to the host. Hyperinflammation is something different. It's the activation of an excessive and disproportionate response that involves both innate and adaptive immunity that is actually developed initially for a reasonable reason, apologies, such as a viral infection, but then gets out of control and eventually leads to significant damage to the host. Most hyperinflammatory syndromes are lethal if not treated. So let's start from autoinflammation. This is Giulio, a classical case of systemic JIA, not a difficult, diagnostically difficult onset. The patient has neutrophilia, a little bit of anemia, platelet counts are increased, fibrinogen is increased because it's an acute phase protein, a little bit of D-dimers, but this is typical of acute and chronic inflammation. Ferritin may go up, and it did go up a little bit. There is no organ involvement such as liver. Is given glucocorticoids for a few weeks, rapidly tapered, started on anakinra, is very happy, and he goes into clinical inactive disease for 1.5 years, and then he shows up and the clinical picture is completely different. The fever is persistent. He has CNS involvement, hypotension, and hemorrhages. His labs are completely different. He has a significant, let's go through them one by one. Bone marrow, there is significant damage to the bone marrow with low platelet, low neutrophil. There is also low lymphocytes, but this is because lymphocytes are probably captured in the spleen. This patient had increased spleen. There is intravascular activation of the coagulation. The dimers are skyrocketing, and there is consumption of coagulation factors, including fibrinogen. There is organ involvement, liver typically, LDH and transaminases are increased, and then there is ferritin. And we all know what ferritin means. Ferritin is released by activated macrophages, activated by inflammatory cytokines. Particularly good is IL-6 in increasing ferritin secretion, but many cytokines can do. And you know that the hallmark of this condition is bone marrow hemophagocytosis. Well, you should not do a bone marrow to diagnose MAS in this patient. The bone marrow may be negative in up to 40% of the patients. And this does happen even in the monogenic forms of HLH, we are going to talk in a few minutes. So this is a typical example of hyperinflammation in which the inflammation becomes excessive and lead to damage to the host. And I like to think that these 6 points are the red flags of hyperinflammation: persistent fever, splenomegaly. There is usually inflammation, so the acute phase reactants are increased. And then there is what I call a poor blood cell count, cytopenia, or absence of increase as one would have expected during inflammatory disease. There is organ involvement. Anyone who gets into an emergency room gets blood cell count, liver function test, including LDH. If you see an increased LDH and a blood cell count which is not as rich as you want it, then ask for ferritin. If ferritin is increased, then you call rheumatology. So where is MAS? Oh, this went out of setting. Apologies. So MS is down here at the very bottom of your slide. You can see this part of the slide shows you only the so-called primary or monogenic form of HLH. And there are two messages here. One, the primary monogenic form of HLH are much rarer than the acquired reactive, which are below here. Let me see whether I can show you this slide in its entirety, because like this doesn't make any sense. What? Just 1 second. I don't know what happened. Oh, maybe you see it now, or you start seeing it. No, you can't. I don't know what's wrong. Anyway, the secondary are much more frequent than the primary. The secondary may be related to infections, may be related to malignant, to rheumatic disease, and in this case, the term MAS applies. They may be related to malignancy. This is particularly true in adults, and then they may be related to nothing. And there is a fourth line down here that is actually almost 30 to 40% of the secondary acquired. Let me go back in presentation mode. Hopefully this won't happen again. Now, how do you get there? The concept of MAS and HLH in general being a threshold disease, a threshold by which a number of contributors bring you as close as to the threshold, and then you get over the threshold and you get into full-blown HLH. And these are genetics. We have talked about the monogenic form. The monogenic form of primary HLH are all due to mutation in genes that have to do with cytotoxic activity of T cells and NK cells. There are infections associated in which the strength of the infecting agent and the genetic background contributes to bringing the patient to the threshold. Malignancy, major role of malignancy, and then there is background chronic inflammation, which contributes to patients developing MAS in the context of a rheumatic disease. Now, this is a different way to see the same thing, but it starts trying to dissect the various contributors to the final storms that involve the T cell activation and expansion and increased macrophage activation, leading to death. And most of these syndromes are fatal if left untreated. Now, as I mentioned it before, it's all defective lymphocyte cytotoxicity, and this is known since, I should say, decades. The original paper from Michael Jordan is published in 2004, where he shows that he could treat mice, not preemptively, but therapeutically treat mice with either interferon gamma neutralization or depletion of CD8 T cells, and these mice are perforin deficient mice infected with this virus. These mice invariably die unless you neutralize interferon gamma or deplete the CD8 positive T cell. They do not survive with a number of other inhibitor of cytokines. This was reproduced in other model of primary HLH, and the accepted model is that instead of normal killing that occurs in patients with HLH, there is a defect in the lysis of target cells. This target cell could be a virus-infected cells in this picture, or could be an antigen-presenting cell such as the DC. And this is a way why activated T cell turn down the response. In the presence of defective killing, you get overactivation of these T cells, huge amount of interferon gamma being produced. These do create expansion and activation of macrophages, particularly the M1 phenotype. This is a counter, how do I say, a balancing mechanism. Indeed, these patients do not die because of the infection. They do die because of the cytokine storm secondary to macrophage hyperactivation. So there is no doubt that the genetic defect in cytolytic activity brings you in here, and the data suggests that indeed interferon gamma is important in the maintenance of this vicious circle. However, it's not as simple as that, as usually in biology. This is a typical experiment in which perforin knockout mice were crossed with interferon gamma knockout mice, and some of the features were found to be independent from interferon gamma in these models. And particularly, these authors found that there was a pathway involving high CD25 overexpression on CD8 positive T cells, and therefore IL-2 consumption. And this pathway was important for some of the immunological abnormalities present in the perforin knockout mice. This is another model showing that in the absence of interferon gamma, there is some expansion of myeloid cells that are apparently pathogenic, and particularly important in this context appear to be IL-33 overproduction, which is a danger cytokines, again produced by myeloid cells. So it is not as easy as that. We have a number of pathways that become involved even in a monogenic disease, such as the genetic defect of the cytolytic pathway. However, the most compelling data regarding clinical application regards interferon gamma neutralization. This paper was published a few months ago in the New England Journal of Medicine, and is the first pivotal clinical trial with the Mapaluma, which is a fully human anti-interferon gamma antibody. In this paper, there were a pivotal population of 27 patients who had failed previous treatment with various drugs that are used in patients with primary monogenic HLH. And here you see the reason why at the bottom this patient entered the study with the Mapaluma salvage therapy. I don't want you to read these slides. I just want you to know that for this trial, we invented some criteria of responses with numbers that were followed to define the response, complete, partial, or HLH improvement of this patient. Here are the numbers in terms of patients who achieved response, complete response, partial response, and HLH improvement. Overall response was 63%, which was statistically different from a pre-specified null hypothesis that in patients who had failed the previous conventional therapy, overall response rate would be 40%. Overall survival was also very satisfactory. Remind you that, for example, in the HLH 204 protocol, which is standard of care for actually the 94 protocol is standard of care. Anyway, 94 and HLH 204 protocol has similar survival rate, approximately a little bit less than 60%, but first line, these are second line refractory patient. Their overall survival rate is 73, and if they made it to bone marrow transplantation, it's close to 90% at 1 year following bone marrow transplantation. I use this trial to introduce to the concept of a new biomarker for interferon gamma production in HLH patients. Interferon gamma is produced not in the blood, but is produced in target organs, let's say liver, spleen, bone marrow, maybe lung, probably. And it's really produced as a very short life, and it gets stuck to the extracellular matrix or to receptor expressing cells. And therefore, it's very randomly measured in the blood. What the trial allowed to do is, following administration, this number is a Mapaluma. As you can understand, this is an early slide in the development of this drug. If you administer a Mapaluma to the patient, a Mapaluma captures interferon gamma in the target tissue, and actually the monomeric antigenic antibody complex gets carried into the blood, and you can measure total interferon gamma levels, which bound to the antibody, which reflects the amount probably produced in the last 20 to 48 hours by the treated individual. And what you can see now is total interferon gamma at 48 hours and baseline CXCL9 correlation, CXCL9 levels in the blood. And as you can see, there are very tight correlations suggesting that baseline CXCL9 do reflect total interferon gamma, being total interferon gamma bound to the antibody, and therefore the amount of interferon gamma that is produced in the body. Measuring free interferon gamma with an ELISA does not reflect the total amount of gamma produced. And this, I think, is a very important finding of the study, in which logistic regression analysis indicated that low CXCL9 levels at the end of treatment were associated with clinical response, and this graph shows you the probability of response as a function of the levels, actually it's log 10 transformed, levels of CXCL9 at the end of treatment with the Mapaluma. So the more you neutralize gamma, as reflected by CXCL9, the better your response. So there is no doubt that this is true, because this is true also in patients. And therefore, this is a pathway that in the mess, if I may say so, of this schema, immunologists, they do like a lot of arrows. At least something is clear. There is, however, another part of this schema here, which is the macrophage hyperresponsiveness and genetics predisposition to this hyperresponsiveness. And I think there have been two recent diseases that do prove the concept. One is NLRC4 gain of function associated disease, which are characterized by recurrent MAS HLH in addition to autoinflammation. And the biological feature of this disease is actually to produce huge amount of IL-18. This huge amount of IL-18 are associated with a number of biomarkers during active MAS HLH episodes, and here it is. CXCL9 is overexpressed in this patient. This is another disease that we identified and published last year. 4 patients that share the same mutation in CDC42. This is de novo. Whether it's a gain of function or loss of function, it does so many things that this protein is so complicated. But again, this patient have 3 linear cytopenia, autoinflammation, and HLH. Again, the biological feature, the main biological feature of this patient is overproduction of bone marrow macrophages of interleukin-18, and I'll point out this column here that shows that in a stimulated condition they are already at plateau. Even if you add LPS plus ATP, you don't get any further increase in IL-18 production. Now, this patient do have, as I mentioned, a recurrent MAS, and again, the best correlation between of ferritin is with CXCL9, again suggesting that there is a downstream pathway that is being associated with overexpression of IL-18 that may involve interferon gamma. But nevertheless, this is true also. You can get in this vicious circle by having hyperresponses and hyperactivated macrophages. However, if we think about MAS in SJIA, and as Jordi and I, as we are pediatric rheumatologists, the first things we think of is MAS in SJIA. And this is a very good model to study the contribution of background inflammatory cytokine production and to understand the different nuances in presentation. Now, these are the criteria for primary HLH as published in the 204 version. And you can see here there is severe cytopenia and very low, I can't find fibrinogen and low fibrinogen down here, which are considered feature. If you look at the MAS criteria that have been developed by a group of people led by Angelo Ravedi, I think you've heard him in this webinar a couple of months ago. These are the criteria, and look at the threshold. Threshold for platelets is well within the normal limit, as well as for fibrinogen. This is just to let us know as clinicians that if hyperinflammation presents in the context of a background inflammatory diseases with high platelets and increased acute phase response, the thresholds are different, and you should actually look at the changing, at the trends of these and other laboratory markers. So I mentioned to you the role of the inflammatory cytokines. If you think SGIA, you think these three guys. IL-6. IL-6 does potentiate the toll-like receptor-induced cytokine production and chemokine production. So is in response to IL-1 beta. So this is a potentiator of the response, essentially. And in mice, this is pretty clear. In mice, transgenic mice overexpressing interleukin-6 in the blood, when challenged with the LPS or polyIC, mimicking an acute infection, they do develop a cytokine storm, they die with increased ferritin and decreased neutrophil and platelet counts. It looks like MAS, very much. Another thing that IL-6 does is that IL-6 interferes with the generation of cytotoxic activity, and this is true in mice, in vivo, following poly-IC induction of NK cells, and in vitro with generation of NK cells in the absence or in the presence of tocilizumab. And if you neutralize IL-6, you get increased cytotoxicity. This web berserk as well, I apologize. I don't know what's wrong here, because I went from home to here, okay? So can you get rid of MAS if you neutralize IL-1 and IL-6? The answer is no, unfortunately. These are trials with canakinumab, this is tocilizumab, and as you can see, there is some cases of MAS who has been rigorously adjudicated during the trials, which with an incidence rate for 100% patient years between 3 and 1 point something. Now, this is still measurable and very evident, but it's probably a little lower than what one would have expected. For example, in Cincinnati and in Rome, we have an incidence rate per 100% year ranging from 4 to 6. So it's probably lower. So you do make things better, but you don't clearly avoid MAS from occurring. Now, while we have very little data on IL-6, we have plenty of data, clinical data on IL-1, because anakinra has been used successfully in many cases to treat MAS in patients with autoimmune disease. This is a case series of 12 patients, and as you can see, most of them, just read the paper. It's a case series, retrospective, multi-center, so it's dirty but full of common sense, obviously, clinical common sense. And you see ferritin improving significantly, and most of the patients resolving their MAS. There is one more recent paper from the group of Randy Krohn, published at the end of last year. I can't write arthritis. Published at the end of last year, showing, apologies, showing, data from a retrospective chart review of, I think it's 45, 42 patients, 44 patients with secondary HLH MAS treated at one single institution in Alabama. Most of them met the systemic GI-associated MAS criteria, and 2/3 of them met the HLH 204 criteria. Even with the use of anakinra, overall mortality is still 26%. And I point out that why in SGIA you can probably do well with anakinra, or this is reported for many patients doing well with anakinra, also in our experience. This is not the case for other autoimmune diseases or other forms of secondary HLH. So we are far from being there. This is a post-hoc analysis, a reanalysis of a prior phase 3 trial of anakinra in sepsis. So this has to do with hyperinflammation associated with infection. And what they have done is that the analysis of the entire population didn't show any statistically significant difference. However, when they analyzed only the group of patients with increase in liver function test and increase in D-dimer, which are indirect signs of hyperinflammation, they saw a significant benefit of anakinra being administered in this patient. So there is clearly a role for IL-1 in some forms of hyperinflammation. Now, but more recently, IL-18 has become particularly fashionable, but I think reasonably fashionable, because the amount of data that's being generated is really compelling. So IL-18 is produced as IL-1 through an inflammasome-mediated mechanism. It circulates bound to an inhibitor, which is called IL-18 binding protein, and only free IL-18 is able to bind the receptor. Now, IL-18 binding protein is an inhibitor, has become a drug, and can be used. And IL-18 indeed predisposes to MAS in patients with SJIA, as shown here, with patients with an active history of MAS having higher level. This is a report from one single patient that was treated with recombinant IL-18 binding protein, tadekinig. He had severe MAS, relapsing MAS. He did better. He was able to taper glucocorticoids some. The MAS episodes still occurred, but were more easily managed. More successful was the treatment of a patient with an NRC4-associated hyperinflammation reported by Scott Canna that really improved significantly following IL-18 neutralization. Now, why is IL-18 become important in MAS? And the reason is probably because of the well-known ability of IL-18 to induce interferon gamma production. And indeed, in patients with NLRC4, for example, interferon gamma production expression in CD8 and NK cell is significantly increased in unstimulated and stimulated condition with PMA ionomycin. But most importantly, sera from this patient in active disease do induce interferon gamma production in the presence of IL-12. IL-18 alone is a co-stimulus for the production of interferon gamma and cannot do it. But if you add IL-12, and then you get significant induction of interferon gamma production by this cell, and this induction is completely neutralized by the addition of an antibody neutralizing the IL-18 receptor, again suggesting that there is bioactive free IL-18 in the blood of these patients. And indeed, IL-18 become important in driving the pathological response in patients. These data are actually from mice, showing clearly that IL-18 binding protein deficient mice do not show pathology. However, when they're triggered by toll-like receptor 9 stimulation, mimic a viral infection, they do develop significant sign and symptom. Here is platelet and ferritin, and they do develop significantly an increase in interferon gamma signature, and again CXCL9 is increased in these mice. And if you neutralize interferon gamma, again they do better. Here is ferritin and ALT shown. We kind of transferred this into human beings. These are 3 patients, 1 with NLRC4, 2 with NLRC4, and 1 CDC42 induced disease. Very high level of IL-18, high level of CXCL9, as I mentioned to you before. They had a very stormy story, receiving all sorts of treatment. Again, this went below, and I'm not going to show it to you. To make a long story short, they started a Mapaluma, patient 1 during sepsis in ICU, and went significantly rapidly better, possibility to taper treatment markedly at 90 days, and you see his ferritin going really down from very high level. Patient number 2 with NLRC4 were less acute, but nevertheless, there was a significant improvement in all laboratory parameters of MAS, and again, possibility to taper, particularly glucocorticoid. Patient number 3 was the CDC42 patient. This is the only survivor of the 4 patients we were able to identify. The other 3 died of HLH. He had a very severe episodes with intestinal infarction and sepsis. He was treated with the Mapaluma with a significant improvement, and as you can see, significant tapering of underlying treatment. So there is no doubt that IL-18 somehow is involved both in increasing macrophage activation and expansion, but also directly driving T cells overexpression and of interferon gamma, and therefore interferon gamma becomes a potential target. Is this true also in MAS, in SGIA? This is a mouse model that we have developed, the one I alluded to before. They develop interferon gamma, increase interferon gamma signature in blood and target tissue. They do develop, and when they are treated with an anti-interferon gamma antibody, they improve their survival, as you can see here, and their ferritin is significantly neutralized. This is also similar to what was done in the repeater-like receptor 9 stimulation model of secondary HLH or infection-associated HLH. Again, if you neutralize gamma, it goes significantly better. Back to human, these are data that we published a couple of years ago showing a significant correlation between CXCL9 and ferritin. Apologies, this is gone again. And ferritin during MAS, but not during active SGIA without MAS criteria being present. This correlation is present for CXCL9 with a number of classical MAS parameters. But again, this is present only during MAS and not during active SGIA, as if the gamma pathway is activated only during MAS. And with this rationale in mind, a clinical trial was designed to test the neutralization of interferon gamma during MAS in SGIA. It's obviously an open-label single-arm trial. Here are the center involved. You see also our chairman here. The two main messages here are inadequate response to high-dose IV glucocorticoids administered for at least 3 days as per local standard of care, and obviously exclusion of those infections. We can talk about this during the discussion. Those infections that are favored by interferon gamma absence. Here are the feature of the patients. Particularly, I like to point out the severity of the disease with the laboratory parameter at screening and at baseline. This is 3 to 7 days with the following treatments being administered in these days, and you see really no response and no improvement. Rapid neutralization of CXCL9, as one would have expected with the dosing regimen of Mapaluma used in all patients. We used as a primary outcome complete response as defined here, which was resolution of clinical signs and symptoms, as well as normalization of the laboratory parameters as indicated down here. All of the patients achieved response. We have now treated 14 patients. All of them achieved response. I'd like to just show you a little bit the time to response. Again, these are the baseline values of these parameters, and these are the median day of treatment by which the dimer normalized, the soluble 2 receptor normalized, ferritin, physician VAS below 1, and glucocorticoid below 1 milligram per kilogram of PDN equivalent. So these results altogether support the pathogenic role of interferon gamma in MAS in SGIA and demonstrate the therapeutic value in patients who have failed the glucocorticoid standard of care. There's one case report that was published I think a few weeks ago of an adult onset still disease patient with MAS failed to respond to high-dose glucocorticoid followed by standard dose of anakinra. He was given Mapalumab and increased the dose after the first injection. You can see a little bit of worsening immediately after the first injection, but then when he is given 3 milligram per kilogram, there is a steady decrease of liver parameter. This is ferritin going down, and in 5 weeks she has normalized everything, and DEXA is tapered back to 2 milligram per day. So even in the context of this rather complicated inflammatory background, it appears that interferon gamma, among other mechanisms, is actually being involved. This is a paper I like a lot, a paper which is from Scott Canna's group, showing that IL-18 level is increased in patients with SGIA, markedly increased in patients with MAS, infection associated, it's all over the place. There are patients with very high, patients with relatively low, as low as the primary familiar HLH. But if you look at CXCL9, CXCL9 appear to be increased in MAS, infection-associated familiar HLH, but not in SJIA, as if you can get to interferon gamma by several ways. One certainly being IL-18. And the fact that IL-18 is important is also underscored by this very recent study, and this is again Scott Canna's lab, playing around with different genotypes of mice, perforin knockouts, homozygous, and IL-18 transgenics overexpressing interleukin 18. And what you see here is essentially the conclusion. I'm just going to tell you the conclusion. Mice that are IL-18 transgenics, overexpressing IL-18, and knockout for perforin develop spontaneous hyperinflammation, okay? Spleen weight goes up, hemoglobin goes down, and everything else is in the sense of, in the direction of severe HLH. And the heterozygous even started doing badly, and if they're hit by toll-like receptor 9 stimulation, they really develop full-blown and severe HLH. But again, this hyperinflammation is associated with high level of interferon gamma as well as high level of IL-18. And if you neutralize gamma, again, you see spleen size decreasing and hemoglobin increasing, so that they come up with this schema that I think is maybe oversimplistic. And Scott would not get up, I hope is not going to get upset with me. I think familiar HLH has this pathogenesis, which is interferon gamma dependent, yes, but other mediators may be involved. There is situation in which there's excess IL-18. Let's talk about, let's think about MAS or NLRC4 disease, which is indeed interferon gamma and IL-18 dependent, because interferon gamma is downstream of interferon gamma, but there is normal cytotoxicity. And then there is mixed all the mess together, okay? It's IL-18 overexpression, partial defect of cytotoxicity, which we have not talked about in this seminar, but which is relevant. And indeed in mice, well, whatever you look, interferon gamma is always increased, and when tested is of benefit. And this is one case report that appeared at the end of last year in a patient with severe ABV-associated HLH, very high infection, did not respond to HLH 204 protocol, ended up with severe cytopenia, a very active ABV and CMV infection. This is 1 million of copies here of ABV and CMV. He receives the Mapaluma and everything goes back into place, despite the fact that because of these infections, they tapered glucocorticoid very quickly. So I'll finish discussing you the beyond, the name. What are these things? So we have certainly mentioned these 3 things here, but there are a number of words that are being used around, particularly in this time of COVID, in which we use all these words without really giving a clear meaning. I think we have a meaning for these 3 first. Everything else is a bit more complicated, and we try to think about this as an umbrella of clinical situation associated with hyperinflammation. There are 2 others that I have not mentioned. HLH is a disease also in adult, and this is a very high unmet need with 30 to 40% mortality. And we are trying to see patients with isolated hyperinflammation in the liver, or with that chronic inflammatory lung disease in SJIA that we don't know exactly what it is. Despite this, I think the future is bright as this sky. We are getting into, we progressively understand the mechanism, the genetics, the mediator, and the cells leading to the various forms of hyperinflammation. There is still a large unmet need, but there are new therapeutic options which are already available. IL-1, probably very soon available interferon gamma, and maybe also IL-18. The JAKs are also available and being tested. I think the future is bright. We need to better understand the mechanism and who is going to be treated with what. And with this, I finished. I thank you very much for the attention. I know that I went a little bit too long. I apologize. And I have to remind you of this. The next webinar has been decided. Here is the title, the speaker, very good friend of mine, a very good speaker, end of December. Thank you very much. I'll take questions.
Thank you very much, Fabrizio, for this nice talk and for, I know it's so difficult to summarize so many points in just 35 minutes. Some questions are arriving directly. In the meantime, could you share some data or your experience of the safety profile of Mapaluma? We have only had a patient, but without significant side effects. But our experience, and we wonder how is it possible with a drug that lasts for months and months in blood. The patient is so well and no side effects till now. So happy to know if you want to share data about that.
So first of all, we are lucky with interferon gamma because, can you see my slide?
Yeah.
Yeah. So first of all, we are lucky with interferon gamma because we know what we can expect. There are interferon gamma receptor deficient humans, and there are humans various degree of deficiency, and there are humans with autoantibody interferon gamma, and we know what they have. They have increased susceptibility to infection to mycobacteria, and increased recurrence to herpes zoster. They get infected with a number of viruses, and they make it out of these infections, even if they are nasty virus, for example, measles. So it's a very selective hole in the defense. This slide shows you the safety data from the primary HLH, the New England Journal of Medicine study. And as you can see here, all the patients, this is a very fragile, heavily pre-treated population. They had a number of events. Infections were present. 13 of these infections were reported as SAEs. None of them, only one of them, one histoplasmosis, was one of the infections that was potentially favored by interferon gamma neutralization, but the infection resolved with normal treatment. All the other you can see here. The severe ones, one fasciitis was reported, was a Pseudomonas fasciitis, was reported as related to treatment with emapalumab. In the MAS study, which I had it somewhere but went berserk, all my table went berserk. I don't know what happened. They were fine 5 minutes before. The only thing I want to draw your attention to is that there was one serious adverse event of CMV reactivation. It was only test positive. There was no sign and symptom, but there were 3 other CMV PCR positive during the study. All of them resolved with ganciclovir. All of them resolved with no symptoms. But still, you know, it's there, and I remind everybody they were very easily treated, but the herpes zoster reactivations of the causing virus are present in patients with who lack interferon gamma activity. I guess that's it for the safety.
That's interesting to know. You have talked about the role of IL-18, and my question will be: do you have experience with the treatment with high levels of recombinant IL-1, 18, and in conjunction with IL-1 blockade? Do you have there is a role for that?
I think there is. Certainly, in the 2 patients that I reported to you, IL-1 blockade was on board together with tadekinig, the IL-18, the recombinant IL-18 binding protein, and I don't think this was dangerous. Although the concept of targeting 2 cytokines may sound dangerous, particularly in the perspective of the FDA, because of their warning on IL-1 and TNF together, but that turned out to be relatively manageable in those 2 patients. I've no direct experience. We have used emapalumab together with anakinra, as you know.
Yeah. And regarding possible new therapies, do you think will be which would you think will be the role for JAK inhibitors in HLH and MAS patients?
I think those are very interesting drugs. And you know they're very close to my heart. I think we have to change our frame of mind. When you target the cytokines, you target one single cytokine, and you hope that the guy is the director of the orchestra or a major player, and then the orchestra will shut up, essentially. When you do use JAK, you cannot inhibit completely JAKs. This is lethal, known in human and mice. So you can dim them. You can kind of inhibit them partially, and by doing so you inhibit a number of cytokines. Some of them are also good guys. Okay, so the risk is clearly the unspecificity of the drug compared to the specificity of a cytokine targeted approach. The advantage is that you can target multiple pathways at the same time. And therefore, I think they need to be tested. There are some initial case reports here and there. I have no personal experience and decided not to comment on those, but thank you for the question. And there is one clinical trial open. I think they just opened at St. Jude. And there are a couple of papers in mice. One of them very optimistic, and the other one is just being published very pessimistic. But I think it's certainly worth to try.
We have another question, and of course, thank you for your talk. Still around 20–30% of patients with HLH are lacking response to current HLH94 new drugs. Which pathogenic pathways are still to investigate? Particularly, is there any anti-IL-33 drug under development for HLH?
Not that I know of. I think that is a pathway. I like IL-33. I think it's a very good target. I think the experiment from Ed Behrens is fascinating because it shows that, well, IL-33 is decreased by damaged cell, and I would say it's a danger signal. And if you think about hyperinflamed patients, they have damaged cells all over the place. So that could be a very good amplifier of an already amplified vicious circle. So I think it's a potential target. I know Ed Behrens is working on it. I'm not sure it's going anywhere as a therapeutic target. I don't think there are clinical trials going on. At least they were not in clinicaltrial.gov.
Thank you. So you just mentioned the lung involvement in systemic JIA that we have started to recognize, well, for a few times now. And what is the kind of relationship you think with this patient? Is like localized MAS, or which is the place you think in this lung involvement these HLH have in these patients?
So to tell you the truth, personally, I thought it was an American problem. It is not, because we are starting to see it here. We are seeing 3 now, which I think is a bit too much. I think you should ask this question to Alexi Grom and Grant Schuler. They have done the great majority of the study, and I enjoy very much the SGIA Foundation conference, which is really focusing on MAS and this strange hyperinflammation. The lung is really an issue. It appears to be IL-18 interferon gamma once again. These patients do have very high incidence of MAS. Almost all of them have had MAS. 60% of them have lung disease diagnosed during MAS. And their interferon gamma pathway, IL-18 and interferon gamma pathway in the lung, it's to the roof. So I think it's a different way to involve a target organ. And then we have those patients with isolated liver involvement. I don't know what they are, but their liver, they have CD163 macrophages, CD68. They have hemophagocytosis in the liver, and they have a lot of CD8. And again, the interferon gamma pathway is to the roof. With STAT1 phosphorylated, with CXCL9 very highly expressed, and other interferon gamma genes. So again, we have to understand the different nuances of presentations of these hyperinflammation. It may be gamma. It's not always gamma, can't be always gamma, can't be that simple, but I think interferon gamma is a potential target that has to be evaluated carefully in clinic.
Perfect. I have another question. My 6-only systemic child IL-10 has always gone in the 300 when in MAS, known Ileris and Chelhans, IL-18 was jumping from 35,000 to 93,000 in 1 month. All other labs are okay. Is still IL-18 a warning of a flare that may be coming?
I might have missed part of the question. Was this under canakinumab?
Yeah, yes, and Chelhans, both of them.
Yeah, so IL-18 is a really strange biomarker, particularly systemic GIA. Our experience, and it's not only my experience, it's a general experience of many of us, is that it stays high even if the patient is doing very well clinically. Now, and there is another minor tweak here and there, and if you inhibit IL-1, you tend somehow to push the system towards IL-18 and interferons, even type 2 interferon gamma. So, and you can, this was first published by Alexi in a very old paper when they looked at expression profiles in SGIA. I think it's more than 10 years ago. And they found that there was this hint of an interferon signature during inhibition of therapeutic inhibition of IL-1 in patients with SGIA. So I think it's not a worrying sign, but it's a sign that there is background ongoing. Whatever is wrong in that patient is still there. So I certainly would not consider this patient as a candidate for withdrawing the biologics, even if the patient has long-lasting remission. This is consistent with the experience from the BAS, from the Utrecht group with their monocenter, well, it's not monocenter anymore, multicenter anakinra trial in SGIA, in which they have shown that IL-18 stays high, sometimes to the roof, over dozens of thousands of picoml for years, even if the patient is fantastically controlled.
Mm-hmm. Thank you. You talk about the genetic background in macrophage related with systemic GIA. Is there a genetic background in infection-associated HLH also? Because it's something that sometimes we are consulted about our colleagues in HLH related with infection. Do you think we must look for a genetic background in these patients also?
I mean, there are some papers out showing that patients with heterozygous or low penetrance variants of genes associated with cytotoxicity and with classical primary HLH may have infection-associated HLH. I think we are far from having understood this. However, there are data here and there. For example, we have looked at the cytotoxicity. This is unpublished. We have looked at cytotoxicity genes in MAS and secondary HLH. While I don't think we have a clear signal in MAS for cytotoxicity genes, and it's 50 patients with MAS, so it's a pretty large group. Certainly the largest that has been looked at. This is Italian. It's the entire country, obviously. In secondary HLH, I think there is a signal, and it's not only the frequency, it's the fact that the patients with the patient who carry the mutation tend to have a higher frequency of ICU admission. There is a tendency towards a higher lethality. So it's not clear cut, but there's something there that we have to start to learn how to look at.
Mm-hmm. We are arriving close to the end of the session. Just considering that there are physicians connected of different parts of the world, and sometimes the resources are limited, which will be your advice about the minimum studies to do in these patients with HLH? Of course, if there is not the possibility to send them to a specialized center. In order to have well categorized ones, I'm talking about the secondary or systemic related macrophage activation syndrome of this kind of patients. What do you think it will be the minimum to these centers have to implement in their clinical settings?
So I think in the diagnostic algorithm, you have to exclude primary HLH. and there's this, and there's no way you can do this clinically. Although one may argue that CNS involvement is more frequent in primary than in secondary, that the cytopenias may be more profound, but this is not the rule in general. So to exclude primary, genetics is too expensive and it takes too long. I think what should have cytometry for periphery and degranulation, and this is not without a significant cost. So I think this is an issue. The other thing that I think will become more and more available even in less resources country is CXL9 and IL-18. So we are developing, for example, a technology based on a micro capillary cartridges that really requires very little blood, one single pipetting measure, and the machinery that is used is clinically grade and costs 20,000 euros, which is a huge amount, but it's not much more than any blood cell count machine. So it's, and these prices will go lower, will certainly decrease in the future. So I think that we are getting there, but at present, there's no way to distinguish clinically from primary and secondary, genetics remains difficult, but DNA is easy to ship, and most of the resources countries will be very willing to provide genetic testing. We do provide genetic testing for free. Not to you, Jordi.
Thank you very much for this amazing talk, and to all of you for attending this webinar. I would like to remind that the next webinar will be on Friday, 18 December at 2 Central European Time. The speaker will be Marco Gatorno, and the topic will be new autoinflammatory diseases and new approaches for the characterization of patients with undefined systemic autoinflammatory diseases. Thank you very much again. Hope to see you soon. Bye.
Thank you. Ciao, Jordi. Thank you very much.